Welcome to this Infectious Disease Detection and Surveillance, or IDDS, project webinar. This webinar takes place 3 days before March 24th, World Tuberculosis Day. We're pleased to present you with this webinar. It will be recorded, and barring technical difficulties, the recording will be shared in coming business days with the attendees. Questions can be posed in the Q&A interface of Teams at the top of your toolbar. And now to our program and our moderator, Andwele Mwansasu.
Thank you, William. Good morning, good afternoon, and good evening, colleagues. Thank you again for joining us. Would love to know where you're joining from, so please write your name and where you are from in the chat function. I'm Andwele Mwansasu. I'll be facilitating this webinar today. Next slide, please. The IDDS project is a 6-year project that operates in more than 20 countries in Africa and Asia. Its scope is to address gaps in health systems' ability to detect, track, and rapidly respond to infectious diseases and drug-resistant infections that pose a significant threat to public health and global health security. Over the past 6 years, the project has collaborated with TB programs to strengthen laboratory systems and introduce new tools, including support the introduction and scale-up of stool-based testing in USAID-supported countries to address the challenges of diagnosing TB in children. Next slide, please. Today, we'll hear about experiences and lessons learned from implementing stool-based testing on the GeneXpert platform from some of the IDDS supported countries, and also we'll learn about new initiatives in advancing stool-based testing. Next slide. Here is our lineup of speakers. We have included the speakers' bios and contact information for you ahead of their sections in subsequent slides. Next slide. We have a packed agenda. The first 4 presentations will share experiences implementing stool-based testing on the GeneXpert platform, and then we'll get to hear presentation highlighting preliminary results and validating stool-based testing on the Truenat platform. After the presentations, we'll have some time for discussions. Again, please enter all your questions in the Q&A function. Lastly, Charlotte Colvin, Senior Technical TB Advisor from USAID, will give us the closing remarks. Next slide. Now I'm happy to welcome our first presenter, Dr. Bibish Kadima, who will share experiences from DRC. Over to you, Bibish.
OK. Merci Andwele pour la parole. C'est Dr Bibish Kadima du LNRM Laboratoire National de Lutte contre la Tuberculose. Je veux vous parler de l'expérience sur l'introduction des sels dans le diagnostic de la tuberculose chez les enfants. Next. Il s'agit d'une étude pilote que nous avons menée en République démocratique du Congo, précisément à Kinshasa, pendant 5 mois, de juillet à novembre 2022. Cette étude, on l'a menée dans 25 structures. Et ces 25 structures étaient faites de 19 centres de santé et 6 hôpitaux de référence. Étaient inclus dans l'étude les enfants âgés de moins de 14 ans. Et comme on l'a dit, les enfants n'arrivent pas à expectorer et qu'ils avalent leurs expectorations et facilement, on peut retrouver de mycobactéries dans leur voie digestive. Raison pour laquelle, depuis cette expérience avec l'étude pilote, la RDC a introduit le sel comme échantillon dans la recherche de mycobactéries chez les enfants. C'est l'algorithme que vous voyez à côté. Next. Et pendant notre étude pilote de juillet à novembre 2022, nous avons eu au total à inclure au moins 815 enfants. Et parmi ces 815 enfants, 793 nous avaient ramené un échantillon de sel. Et parmi ce groupe d'âge, parmi ces enfants, selon le groupe d'âge, nous remarquerons qu'il y avait plus d'enfants de 0 à 4 ans qui étaient inclus dans l'étude. Et les deux sexes étaient représentés de la même manière dans tous les groupes de tranches d'âge. Mais pour ce qui est de la détection, parmi les 793 échantillons de sel analysés, on a eu 134 échantillons qui sont revenus positifs. Donc, on a eu à diagnostiquer au moins 17% des enfants. Et parmi ces enfants, le résultat, selon la charge bacillaire que nous avons retrouvée, c'était plus des résultats traces à 43%. Et parmi ces 43% de résultats traces, next, il y avait au moins 63% des enfants âgés de moins de 2 ans qui avaient des résultats traces. Ce qui prouve encore que ce tranche d'âge-là de moins de 2 ans font beaucoup de la tuberculose et comme ils n'arrivent pas à expectorer, on peut facilement retrouver des BK dans leur selles. Next.
Hi, Bibish, quick, can you check with your microphone, please? We cannot hear you.
OK.
Yes, it's better here.
Bien.
Perfect.
Après avoir, je parlais du cas de l'enfant de 10 ans, âgé de 10 ans de sexe féminin, qui était porteur du gène SS, donc il avait la drépanocytose avec une suspicion de mal de Pote. Mais il avait une confirmation à la tuberculose avec les selles. Et non seulement il y avait une confirmation à la tuberculose, et cet enfant aussi était résistant à la rifampicine. Son état de santé était très critique. Et 2 semaines seulement après son traitement, l'enfant avait retrouvé son état d'avant. Next. Quelles sont les leçons que nous pouvons retenir de cette étude? D'abord, si cette étude a marché sans problème, c'est puisqu'il y a eu une maintenance de toutes les machines GeneXpert qui se sont faites avant le lancement de l'enquête et tout au long de l'enquête, nous avons eu une équipe avec laquelle qui nous aidait à faire cette maintenance. Et ce test-là, sur le sel, n'était réalisé que chez les enfants qui n'arrivaient pas à expectorer. Et une fois qu'il y avait un résultat qui était invalide, non résultat ou erreur, ce résultat-là, cet échantillon-là a été répété pour avoir un résultat valide. Et même parmi les résultats répétés, on a eu 6 cas positifs. Et seuls les techniciens de labo qui ont été formés sur cette technique peuvent l'utiliser. Et enfin, la supervision qui a été trop rapprochée des activités nous a permis chaque semaine d'évaluer les indicateurs clés pour le suivi de l'étude. Et ces indicateurs clés nous facilitaient la tâche pour faire nos supervisions, aller vers les sites qui avaient des problèmes et résoudre ce problème-là. Et quelles sont les étapes que nous attendons pour y arriver, pour étendre cette technique au niveau de tous les pays? D'abord, nous avons déjà planifié pour l'extension de ce test dans tout le pays. Et nous avons introduit cette nouvelle technique dans notre guide de laboratoire et avons formé déjà les techniciens de laboratoire provinciaux. Mais cette technique ne doit pas seulement s'arrêter au niveau de laboratoires provinciaux, mais ça doit aller jusqu'au niveau de laboratoires périphériques. Et les laboratoires qui ont été inclus pendant l'étude, ces laboratoires-là continuent toujours à faire cette analyse en dehors même du pilote. Et pour ce faire, pour avoir des résultats positifs avec cette technique, il faudra non seulement former les techniciens de labo, mais aussi capaciter les cliniciens sur la présomption de la tuberculose. Car si le clinicien ne pose pas un bon diagnostic, en screenant le vrai présumé TB, on n'aura pas de résultats positifs. Et comme je le disais tantôt, on doit former le reste de l'équipe des autres techniciens de laboratoire sur cette nouvelle technique. Next. Et là, vous avez nos photos sur terrain et même pendant nos formations. Je dis et je vous remercie.
Thank you, Bibish. I apologize for not informing you that our presentation will be in French. We do hope that you are able to follow the English translation on the slide. Again, if you have any questions for Bibish, you can put them on the Q&A faction. They'll be answered, and we'll have a French translator for that. Thank you. And thank you, Bibish, for your presentation. Now I'm happy to present our next speaker, Diosdelio Malamule, to speak about experiences in Mozambique. Over to you, Diosdelio.
Thank you, and everyone. My name is Diosdelio, and on behalf of Mozambique, I will share the experience that we had during the SOS method implementation. So next slide, please. So the strategy adopted by Mozambique when we are about to implement the SOS method was to start with the TOT for master trainer in Uganda. So this TOT could participate one pediatrician from National TB Program, one lab technician from National TB Reference Lab, and also two implementing partners, one from University of Maryland, Baltimore, and myself as IDDS project. So after the TOT training, we had the PPT material, and we had to work through translation into Portuguese and also to accommodate some specific terms into our local context. For this exercise, we scheduled a workshop with our technical working group composed by clinical and lab expertise. It's also important to note that during this workshop, we also had a discussion related to development of the national plan for SOS method implementation that was already developed by National TB Program, as well as some SOPs and job aids that could help the lab technician during the exercise in the field. So once the material was also ready to be implemented or ready to use, we planned the cascade training to cover the 11 provinces that we have in Mozambique. So these 11 provinces were also trained into 3 different phases. In phase 1, we scheduled for 4 provinces, and we could train 30 people as a TOT. So after this TOT training for 30 people from Maputo City, Maputo Province, Nampula, and Gaza, you also could scale up training in Nampula, where 43 health professional workers were training. And then we cascade the training to phase 2 and phase 3 to cover the remaining provinces. So next slide, please. So here, after the implementation and different sites that we have, we can see that in total we have 89 sites except Zambezi and Cabo Delgado. Zambezi and Cabo Delgado, they did not start the implementation due to some logistic issues, but I'm sure as soon as possible they will be able to start the training for SOS. But all the provinces, as I mentioned before, has already implemented the SOS method. And in the next slide, we can also see some preliminary results for at least 4 provinces, because it's also important to note that the times of implementation for each province were different. We started from December, and it means that other provinces already started in February. Majority of the provinces started in February. So next slide, please. So here we can see our preliminary results for Maputo province, Sofala, Niassa, and Nampula. So for Maputo province, from December to February, they could be able to process 167 samples, that 161 were negative and 6 were positive. In terms of positivity rate, at this stage, we can see for Maputo province, we have about 3.59, and for Nampula as well, they processed 64 samples, which 56 were negative and 8 were positive, which the positive rate is 12.5. So for Niassa and Sofala, despite the number, we can see that it looks low, but they could have at least 1 positive case. So this is also good in terms of the current picture that we have, because we can see that in terms of TB, bacteriologically confirmed, we can have, at least in each province, some different outputs if you compare with the data in the past. So next slide, please. So in terms of lessons learned during the implementation, we could realize that it's very important to have a very well-established technical working group to also support in the contribution for the easy implementation of SOS method. And also the commitment of the top management was also key, because if we have this top management commitment, it also supports the SOS implementation, especially on the release of budget to support the cascade training in the country. That's why we could start from some provinces, and at the end of the day, we could have a different sites implementing the SOS because of this commitment of top management. And also, as what we learned, is also needed to have an adequate planning for logistics for SOS method, especially ensuring that all the equipments are ready to be used. Because if you are planning to start a different technician or a different method, it's also important to make sure that the machines could be able to serve the specific term. So that's why in this phase, we could learn that it's also important to have all the GeneXpert machines full function, and also the full support of implementing partners to support the scale-up training in their respective provinces. So as the next step after this exercise that we did is, of course, continuing monitoring all the sites with the SOS implementation, because during this monitor, we can also evaluate the errors and also some difficulties that the facility could face, and also ensure availability of materials, especially to prevent or avoid the stock out, and also make sure that we have support of the implementing partner to support the scale-up training in the province that did not start. As I mentioned, we still have, for example, Zambezia and Cabo Delgado that didn't start the SOS method. So if we have some support of implementing partners, would also make it easier and to start the implementation. So next slide, please. So here we can see some pictures in terms of the exercise that we did during the SOS implementation, such as a workshop and also the field work that we had. So thank you.
Thank you, Diosdelio, for sharing your experiences from Mozambique. Our next speaker is Liberty Havazidi, who will be presenting experiences from Zimbabwe in scaling up stool-based testing. Over to you, Liberty.
Thank you very much, Andwele. So I'll be presenting on behalf of Zimbabwe. Next slide, please. So we've had a situation where we've had a gap in terms of our incidence notifications, particularly in the age group 0 to 14 years. So chief among the causes has been the issue to do with child-friendly specimens. So this then became our sort of initiative towards our implementation approach, where we then were to introduce stool testing in all of our 130 GeneXpert sites. So to date, we have been able to do that. And I think what is quite important is our model has been based on training and support supervision visits. And then we also intend to do monitoring through data review meetings. Next, please. So our roadmap has been such that from 2019 to 2021, we had a pilot that was done through AgPath. So this was more of a pilot research program through the CAP-TB program. And then thereafter, we had a gap where we then did a national TOT. In this national TOT, we then had all the 10 provinces represented in terms of our laboratory personnel, clinical personnel. And then what we then had in mind was once we trained these cadres, they would then cascade to the regional level. So I'm pleased to say we also had KNCV, Uganda SRL spearheading this training. So after the regional trainings, we then cascaded our trainings to the 65 districts for all our 10 provinces. So these then made sure that in terms of the SOS method and the whole childhood cascade trainings were done in this respect. Then after that, we moved to support supervision visits. So we had a standard checklist that was eliciting some responses. Then what we then did was we had different teams from all the provinces that were represented. After that, we then propose, or going forward, we will do some data review meetings just to make sure that we monitor progress. Sorry. Thanks. Next, please. So looking at TB notifications in 2023, we did realize some positives in that we've had a gradual increase in terms of our proportion of bacteriologically confirmed pulmonary TB. So yes, we attribute this to the SOS method, but also suffice to say there are other interventions that have come into place as well to augment on this. Next, please. Just zero in on the laboratory tests. So what we were trying to look at was the number of tests, of which the number of tests that we've had is 14% of our tests have come from stool samples, which is quite a good start. And of these 3.7% have been failed tests. So analyzing this, we did note that there was a lot of invalid tests. So these invalid tests we have attributed to sample management issues. So as we were also doing our support supervision visits, it became key that we also emphasize the need to stick to the standard operating procedures so that we minimize on this. So our positivity rate has been around 1.7%. I think bearing in mind the highest we've had in one of the provinces, about 8.7%. We expect this to be on the rise as we move on, as we also ensure that most of our provinces are at par in terms of making sure that the interventions that we put in place are actually accommodated within their operations. So in terms of the positives, MTB positive results, 11 of our results were trace results, which then are treated according to our national algorithm, which treats this as positive cases. Then also we had one positive result in all these interventions that we have done. Next, please. So zeroing in on the 0 to 9 year age group from 2021 to 2023, what we've noticed is a gradual increase in terms of our BACT confirmed. So this is quite promising, but we hope that going forward, as all the provinces start to gain mileage in terms of knowledge acquisition, we should then have a higher peak in terms of BACT confirmed cases. Next, please. So as we were also going around with the NTP and partners as we're doing our support supervision visits, we're quite pleased when we came across a case where they had isolated an MTB positive. So to them, they were quite enthusiastic in that this was their first positive case. And what the head of department then highlighted to us was this was quite key in terms of motivating the staff to continue using the stool specimen. Before we had quite a number of questions whether we could actually recover MTB positive from a stool specimen. So this was quite key for us going forwards. Next, please. So what are the key lessons that we have learned through all this? So what we've learned is that capacity building is quite key in terms of uptake of stool-based testing. In most of our provinces, we've noticed that after the trainings, there is quite a significant increase in terms of using bacteriological confirmation. So this is quite key for us. Then what we also then managed to do was to integrate clinicians and lab personnel as we're doing our support supervision. So what this has aided is, as we move, knowledge acquisition and implementation has been easier in that both the lab and clinic side have been on the same board. Then we've also noted in terms of lessons that utilizing the STEM strategy, which ensures that all clients that have an interface with a healthcare facility are actually screened for TB, actually helps in terms of having more presumptions. And the more presumptions we have, that also adds to the SOS method. I keep on stressing on demand creation because we cannot work in isolation. We need the specimens, but have to come from the clinic side. So contact tracing can never be underestimated. That becomes another intervention that needs to augment these processes. So another issue or lesson that we also garnered from our initiatives was the inclusion of other partners. We also had the opportunity to have Uganda SRL, Zambia, and other stakeholders that had already done this before us. So this gave us an insight into what we needed to change and all the initiatives that we needed to have going forwards. So what are our next steps? Our next steps will involve gap filling. We did notice, particularly in our support supervision visits, tools and guidelines are key. Most of the health facilities need this to then stick to the new interventions that we are having. So that can never be underestimated. We also, as we were doing our support supervision visits, we had some action points that then should guide in terms of closing the gaps and also then speak to more notifications going forwards. Then another key area that we noted was the limbs. We did notice that in terms of limbs, we need to expedite our efforts to make sure that all the GeneXpert sites have the limbs TB module in place so that we can ensure traceability, turnaround time of results is ensured. Then conduct national, provincial childhood TB data review meetings is another item that we need to run with. So at present, we have this as a monitoring tool to ensure that we're always in touch with what's happening post trainings and support supervision visits. There's also a review of and dissemination of the child and adolescent TB test guide that needs to take place. This will capacitate our healthcare workers to make sure that they are doing everything according to the guidelines. Next, please. So I'd like to thank you. At this moment, also allow me to extend a lot of thank yous to a lot of our stakeholders, the Minister of Health, through the AIDS and TB units, USAID partners, and all the other partners that continue to spearhead childhood TB initiatives. Thank you. Over to you, Andrew.
Thank you, Liberty, for sharing showing us how Zimbabwe is scaling up stool-based testing. Our next speaker is Dr. Samuel Shirwa, who will be presenting experiences from Malawi. Welcome, Samuel.
Yes, thank you, Andre. Yes, so I'm Samuel Chibra, and I will be presenting the experiences for Malawi on behalf of the National TB and Leprosy Examination Program and also the Ministry of Health. Thank you. Next slide. Yes, so I'm sure we're all familiar with the SOS, the simple one step, as it was described by Petra in 2021 and team. So we, as a country, this had already been recommended by the WHO. So we set out to see how feasible this would be in our setting. So we are not out there to try and prove whether SOS works, but rather how would it perform in our own setting and how integratable would it be. So we conducted a cross-sectional descriptive clinic-based, which was mixed quantitative and qualitative study, including, so this was done in 8 hospitals, a mix of public hospitals and also the private, especially the Christian Health Association hospitals. The target group were children as defined from 0 to 14 years old. And this took place from November 2022 to May 2023. Next slide, please. Yeah, so we managed to have around 578 recruits in that pilot, of whom 520 had valid results. This was mostly due to the way we set up our M&D systems. In the first month, we lost a number of linkages in terms of valid results. But eventually we managed to diagnose 31, we detected 31 MTB in stool samples out of those 520. And then of those 31, 4 of them had a rifampicin resistance. So on your far right, you will notice the level of detection. So this was not a surprise for us because the majority of them had trace of very low cause on GeneXpert. So this is not surprising based on the fact that children have post-bacillary TB. So this was consistent, of course, with other findings in other settings. Next slide, please. Yeah, so of course, this is a rather clouded slide, but I'll just summarize. So this was a child who was HIV negative, had presented with a neck swelling, had a contact history about 8 years back. And so we, on exam, he was rather stable, but upon doing a stool GeneXpert Ultra, he was found to have MTB detected. At the time, the country was conducting an operational research, implementation research rather, on a shorter regimen. So he was enrolled into that regimen of GRTB and finished the entire course of the treatment and made a full recovery with the lymph nodes regressing and went back to school. Next slide, please. Yeah, so based on this feasibility study rather, so it was a pilot, but rather to look at feasibility. So we found that stool was acceptable amongst healthcare workers. It was rather easy for healthcare workers to obtain stool, and also the simple one-step method was very easy for lab officers, and also the guardians found it more acceptable as compared to, let's say, a nasogastric aspirate, for example, which is rather invasive, and most guardians are not comfortable with such techniques. And then on top of that, we found that processing stool in this way was feasible and could be integrated into a routine, the routine healthcare setting in Malawi. Yeah, so in terms of the way forward, the country has integrated this into the national guidelines and plans to scale this technique up across the country. And this, of course, will be done in, it will be a phased implementation. starting in July. We are also intending to publish this. We're still looking for journals. We already have the manuscript, so we'll publish this at least to share with the world and see whether they can adopt or even attempt something similar to this. That's the end of my presentation. Thank you so much.
Thank you, Samuel, for sharing Malawi's experiences. Please, as a reminder again, do send your questions in the Q&A functions for the first 4 presenters as we are moving along to the next 2 presenters, which will be presenting on the early findings and learnings from doing stool testing on the Truenat platform. And our next presenter for this is Joel Kabugo from Uganda. Over to you, Joel.
All right, thank you so much, Andere. And I'm going to be presenting on behalf of my colleagues from SL Uganda, research that was done to test out how stool can be tested on Truenat and also Expert MDR. So it was done in collaboration with other teams, that is CanTV and Connect TV. Next slide. So to start with is that I'll take you through this experimentation we started to undertake on how stool can be tested to diagnose TB on new diagnostic techniques. So it should be noted that bacteriological confirmation of TB in children still remains a challenge due to the fact that collection of conventional samples in this age group is really hard, and other variable samples are quite invasive and require skills and a certain degree of infrastructure to perform them. So, but by 2020, a studies had shown that a stool can effectively be used as a sample for bacteriological confirmation using GeneXpert Ultra. And with this knowledge, we wanted to see how we can use this understanding to scale it down to the new molecular diagnostic techniques, that is Truenat and MTB-RIF, and the MTB-RIF, the MTB XDR cartridge. Next slide. So we set out 4 objectives, and the first one was to see the performance characteristic, given the fact that we already know how Ultra weighs. So we wanted to compare the specificity, sensitivity, and accuracy of the MTB Plus versus the Expert Ultra when we tested still using it. Then next, we wanted to see how is the rifampicin detection using the MTB-RIF DX, and then when we compare it with stool tested on Expert-RIF Ultra. So in addition, we wanted to establish the optimal, minimum, and maximum amount of stool to be used for SOS on these new techniques, on the new molecular diagnostic techniques, where it has not yet been verified or validated. But we also wanted to determine the limit of detection when it comes to processing stool using the Expert MTB XDR assay. Next slide. So our study set out in such a way that we adopted the SOS protocol and incorporated this into the existing testing algorithm and procedures of Expert XDR and also Truenat. And as you can see in the diagrams above, so the practical experimentation was very easy, given the fact that we had preliminary understanding of what to do. Next slide. So in performance of this study, we downgraded it into 2 phases. So that is phase 1A and phase 1B. So in phase 1A, what we did is that we broke this into 3 series, that is Series A, Series B, and Series C. And in Series A, we did 5 runs. And of these 5 runs, we are varying the different amount of stool, but we are using the same concentration of bacteria. So what we did is that we did inactivate 837 RRV, and after inactivating 837 RRV, we did carry out dilutions, serial dilutions. And in Series B, here the serial dilutions were varied from 10 power 4 to negative. And in this case, we didn't use stool. And then in Series C, we used the same quantity of stool that we had determined using Series A, so that we can see what level of inhibition is there. So here we varied also the different concentration of bacteria. So to summarize that is that in Series A, it was used to define the optimal stool quantity to be used for Series C, and then Series B was used to measure the level of inhibition from stool tested on the same series of bacterial dilution. Next slide. So let's look at our results, how they came out. So it can be noted that the graph above shows results of experiment A, where we are having different quantities of stool, but tested with 10^4 bacterial suspension. So in this, we can see that our results were run successfully for Truenat MTB plus, but we are varying from 0.05 grams to 0.15. So, but when we came to 300 and above and with liquid stool, we did not get successful results. We got errors and invalids, and we had to stop testing for this experiment using the listed grams and on the liquid stool. So, but we can see that increase of stool quantity did not show a significant increase. As you can look at the CT values, we mainly looked at RPOB1, and then for Truenat, we concentrated on looking at the CT MTB plus cycle-threshold values. Next slide. So also in comparison of series B and series C to look at the levels of inhibition is that given the fact that same quantity of stool now was being used, that's 100 grams. So we wanted to see how is the dilution coming out. So CT values increased with decrease in concentration of spiked bacteria, but then we saw minor differences in CT values between series B and with 100 milligrams tested in series C. So Truenat in our experimentation of phase A showed slightly more sensitivity compared to ultra. Next slide. So when it comes to expert XDR, here all the grams from 100 to up to 600, we got successful results, which is quite very promising. But one of the downgrades is that if you have MTB trace detected on expert XDR, given that expert MTB ultra, expert MTB XDR is a reflex assay, you may have a negative. So that's what we found out in this study. Next slide. So after finding out results from phase 1A, we went ahead to start on our next phase, which is phase 1B, which is targeting on testing the findings on clinical stool samples. And so far we've had 10 positives and 17 negative stool. And this we have so far 100% agreement, but we are testing using 100 milligrams, and we are using 600 milligrams as our reference. So we are testing also on ultra and XDR at the same time. So the way forward is that this type of setup is also being rolled out to other settings, that is Nigeria and also other study sites in Uganda, to see how this can be cascaded and also started to be used on the new molecular diagnostic techniques. Thank you. Next slide. So that's part of our experimentation, and those are some of the team members who did the experiment. Thank you.
Thank you, Joel, for sharing these interesting and promising results of the experiments that you did. The second phase of the Truenat work was implementation in routine setting. And for this, I'm happy to invite Jamiu Olabanji from Nigeria to share their experiences. Over to you, Jamiu. Welcome.
Yeah, thank you, Andrew, and good day, everyone. I will be presenting the preliminary result of the routine evaluation of stool-based testing to diagnose tuberculosis using Truenat platform in comparison with Expert Ultra. Next slide, please. Next slide. Okay, thank you. Our major objectives, we have 6 objectives undergoing this study, and we want to actually determine the MTB and rifampicin resistant rate and also non-determinant rate using the 2 platforms that I just mentioned and the developed SOP from the Uganda presentation that we just listened to. But however, in this case, we're actually implementing this in routine settings, just like I said from the topic, using sample from children with presumptive TB. So the children are naturally children that visit the hospital, and they have been screened using different platforms to identify them as presumptives. So we're collecting these 2 samples from them for these 2 platforms. And also we are looking at the sensitivity and specificity of these 2 techniques while comparing it with the existing platform, which is the use of Expert Ultra for stool testing. And we are looking at the operational characteristics and feasibility of this stool-based testing on Truenat platform. We're also looking at to generate enough evidence that is needed to actually scale up this testing, the use of stool on Truenat platform, while we are still comparing the cost difference between the two platforms as well. Next, please. Next slide. Next slide. Okay, I think due to the network difference, the next slide is not coming up yet. But for the people that are seeing the next slide is actually showing the data overview of what we. Okay, thank you. The approach method as well. We actually use a descriptive mixed method study for this research work, and we selected 2 states in Nigeria, which is Osun State and Oyo State, out of which in those states we actually engage 36 laboratory, 6 GeneXpert, 6 Truenat laboratories and 30 GeneXpert laboratories, and also 35 healthcare facilities that actually span across all the 3 tiers of healthcare settings in Nigeria, as we can see from the slide. And our study population is children between the age of 0 to 14 years old, and also healthcare workers for the feasibility studies and other qualitative studies that we want to do on the study. And we have a sample size of 500 children to be enrolled on the study, and healthcare workers from the selected facility as well to be enrolled for the qualitative studies. Next slide. So the data overview so far on the study, we started enrollment in February, 12th of February this year, and up to March 13th, 2024, we've been able to enroll 427 participants on the study, and all these participants, 43 out of them were able to produce a respiratory sample alongside with a stool sample that they were able to produce during their engagement. And all the 427 participants were able to give us a stool sample, and the sample were referred to both GeneXpert and Truenat laboratories, because our method is to collect 2 samples from the same participants, while we take one to Truenat, the other to our GeneXpert laboratory. And so far on the study, as at the time of this report, we have collected 421 results so far, and we are currently at 85.4% enrollment rate. Thank you. Next slide. So we looked at the age and sex disaggregation on this study, and looking at the age and sex disaggregation, there's the age group between age group 2 to 5 actually has the highest frequency, with 163 participants falling within that age category, giving us a 38.2% out of the total participants that were enrolled. And we also noticed that male are actually 222, which is higher than female among the participants, who happens to be 199 participants for female. Next slide, please. So we did a cross tab to have a deep look and do a kind of comparison to have full understanding of the concordant and discordant results that we obtained from these 2 platforms. So you'll see the GeneXpert laboratory result that we're able to obtain from GeneXpert at the top, while by the side we have the Truenat. So we did a cross tab of these 2, and we realized that 2 participants actually have a strong, they have strong concordant positive results, which are color-coded lemon. And we have concordant positive results as well that are color-coded yellow, that is with varying level of concentration of bacilli in terms of detection from the 2 platforms. And if you look at the orange, the color-coded orange part is pointing us towards discordant positive result. These are positive results that one of the platforms were able to pick as platform actually give actually color-coded red. We have 361 participants actually that fall into that category. So this gave us an idea of what each platform is picking and the concentration that is coming out. So the next slide, please. So this particular slide, we now decided to summarize what we have been able to get from the crosstab as well and on the study, and to compare the results in terms of MTB detection. At the middle, you will notice that we have 6 MTB on both. That is, both GeneXpert and Truenat have concordance on 6 MTB cases. That is, 6 participants were able to get MTB detected from the 2 platforms. But if you look at my right-hand side where we have the Truenat, 7 MTB on Truenat only. That is, Truenat was able to detect MTB in 7 samples. And when you look at such sample at the other end, which is the GeneXpert, GeneXpert is giving another result that is not MTB detected. And we also looked at what GeneXpert was able to pick. GeneXpert also picked 14 MTB detection on experts only. That is, on the other hand, when you look at Truenat for the same patient, the Truenat is giving another result, which the previous table has just explained. So in total, so far, we have been able to detect 27 MTB cases, and we have been able to place them on treatment, on appropriate treatments. Next slide, please. So the lessons learned during the course of this implementation is the stakeholder engagement is actually key to the sources that we recorded so far, from National TB Control Program to USAID to State TB Control Program and others supporting partners, including IDDS, for the opportunity. And the technical training that we actually carried out was key among the laboratory personnel to adoption of the SOP, where we have both the practical and the theory section. We did one-day sensitization of healthcare workers to prepare their mind and also engage them and train them on how to counsel the participants for this study. And that is also key. And enrollment, because of this training, the enrollment was actually at a high speed because all of them are aware of the study and the benefits that will come from successful implementation of this. We also develop IEC material. We want to make the implementation seamless and also make sure that people get whatever they miss in one way or the other during the training when they are already on the field. So we did optimal sample logistics because we realized that sample logistics is very key to successful implementation of stool-based testing on either GeneXpert or Truenat based on our previous experience. And daily reporting was key to actually for us to be able to plug the gap and fix any issue that come up on the field in real time. We did intensify supportive supervision as well to be able to guide our facility people and also to make sure that they follow the SOP. But the greatest asset that we have on this study is actually the teamwork, as everybody were working together collectively to make sure that the study is a success. We're still enrolling more participants on the study as part of our ongoing activities, and the MSP is still going on, and data collection and review, enrollment of participants on TB treatment, because we realize it's not enough for you to diagnose a child, but you need to place that child and ensure the child is on treatment. Data validation on our COBO2 is still ongoing. So next. So thank you so much, and we acknowledge and we appreciate the efforts of USAID, NTBSCP, IHPN, and every other person that make this a success story. Thank you.
Thank you, Jami. As you can see, everybody is clapping for you. These are very exciting findings from Nigeria.
Thank you.
We have now come to the question and answers part of our program. Please do include your questions and answer in the Q&A function. My colleague, Eric Reinsdorf, will help facilitate this session and read the questions that are posted in the Q&A. Over to you, Eric.
Thank you, Anjali, and thank you, speakers, for sharing your experiences and your expertise on the pediatric stool TB testing. Wonderful, wonderful presentations today. So again, if you have questions, please place them in the Q&A. And we have a few minutes for those to be answered. So the first question is, can the presenters explain how or if this new stool process for diagnosing childhood TB was explained and socialized to parents? Was there any hesitancy amongst parents for providing stool samples for their children?
Okay, is the question to me, or can I take the question?
Yes, you can.
Okay, thank you. We started the use of stool 2020 as soon as the WHO sent out the guideline and approved. USAID TB on 3 projects, we actually swing into action and train people. So most of our people, with the number of webinar sensitization, NTBSCP, making it like everybody is aware in the country that the use of stool for diagnosis is, we have that platform. So the sensitization actually helped in terms of preparing the mind of the people, even the patients and the healthcare workers as well. But in the initial stage, we had such challenges where people will be hesitating to give their sample. And that's why when we want to start this study, we did one-day sensitization for healthcare workers, where we actually focus more, because the sample collection is not that different, because it's something that they've been doing, but we focus more on their counseling skills. So how to convince people that this is what this is meant for. And remember that the children that we enroll on the study, at least for Nigeria, in our own case now, the children that we enroll are actually children that actually came to the hospital because they are not well, and they are screened, and the clinician has said, go for TB testing. The encounter with DOT officer, we have officers on the field that are actually focusing only on TB treatment. But when you get there as a parent or as a caregiver, they're now telling you that your child has access to this testing platform, and they know it's not invasive, and they are actually good to go. So it depends on the approach of the healthcare workers, and that's why we spent a lot of time giving them enough training in terms of counseling skills and how to administer the informed consent and assent form, because getting the informed consent from the signed and understood by the parent is not enough. We still go ahead and ask the child whether you want to do the test.
Okay, thank you very much for that. So the next question is regarding, is probably for Joel. What is the cost implication of both testing platforms, and how is it affecting the implementation financially?
Okay, thank you. I think the cost implication study is still ongoing. We have we have a consultant working on that, and we're collecting the data right now so that we can have just like I said, this is the preliminary results. At the end of the day, we'll have what the cost implication is. I think Nyansha is the one in charge of that.
Okay, thank you. Liberty, go ahead.
Yeah, sure. Thank you, Eric. So maybe just to add on what the previous speaker has been alluding to, I think what we notice is, because already this has been a specimen that was collected in terms of microbiological tests, so it wasn't so difficult to then transition and say, we are asking for a specimen where your child can be helped. So going forwards, because of the non-invasive nature, we don't see any challenges in terms of collecting the stool specimen. Then in terms of issues to do with cost effectiveness and all that, I think going forwards, countries have then to start also when they do their quantification based on data. This is why it's critical to then collect very informed data, then project what are the needs. Obviously, we are going to have more of testing in terms of the SOS method that normally ordinarily we don't have with other specimens. So it's just about then having our quantification in place to then say, with the data that we have, how much do we project going forwards? Thank you. Over to you.
Thank you. And I think Samuel wanted to comment as well. Go ahead, Samuel.
Yes, thank you. So in terms of acceptability of using a stool sample for testing, for diagnosing TB, maybe just a bit of a brief background. In our setting, we sometimes encounter challenges in terms of if a child needs oxygen, for example. Just the idea of having a child on a mask is associated with bad stigma and myths and so on. And then procedures such as NGAs, which have to insert a nasogastric tube and then try to suction. Those are not well received in our setting. But when it came to stool, according to we did a qualitative assessment as well. We interviewed healthcare workers. So we did not interview guardians, but healthcare workers. And they reported that guardians were more accepting of bringing a stool sample as opposed to other means of diagnosis. So in terms of acceptability, I think that was our experience. Of course, when we were disseminating the results of the SOS pilot, the question arose that what was the attitude towards SOS and submitting a stool towards diagnostics. So since from a scientific point of view, we did not actually interview the guardians, we only got information from healthcare workers concerning the attitudes of the guardians. So we thought maybe in the future we might conduct a research in terms of the knowledge, attitudes, and acceptance from the guardians. But from what we had as an experience and from what was reported from the healthcare workers, stool was well received among guardians. Thank you. Over.
Thank you, Samuel. So we have one more question here that I think we have time for. Is for Olambiji, is related to how did you collect sputum samples from the children, especially those under 5?
Okay, thank you. If you look at the age group, for children under 5, it will be difficult for you to get sputum. And even when you try to say you want to collect sputum, they might actually give you a saliva or probably salivary sample. And most of the children that were able to produce sputum, because out of the 427 participants that were enrolled so far, only 43 were able to produce sputum. And most of those children that were able to produce sputum are actually between the age of 10 and above. So, so we are looking at that, okay, at least if you instruct them on how to produce quality sputum, those age group can still manage to. While some of them, even even within that age category, they will still not be able to produce sputum. But getting sputum from children less than 5 years old, then you have to resort to NG, nasogastric aspirate. But if or other invasive method. However, most of those parents will even prefer, just like the other speaker said, to get this stool rather than allowing their child to go through that process that require a kind of experienced clinician to handle that process. And the cost, despite the fact, what we're implementing in public health is actually a kind of cost-effective approach and a patient-centered approach. So looking at all this together, we will look at the cost implications on the parent getting the material for any form of invasive method to use rather than getting this tool that is readily available for every child. So for those age category, we don't actually advocate for that, and you can't even get quality sputum from them based on the experience.
Thank you. And Dwele, I think we should turn it over now, if there are no more questions. Oh, I'm sorry, Samuel, you have one quick comment to make?
Sorry, my apologies. I still had my hand raised after the initial comment. Sorry.
Okay, thank you.
Thank you, Eric. So maybe for the first question that you asked about how did they get parents to agree to collect sputums, maybe if Evelyn can help us translate that for Bibish and see if she has a different response. Over to you, Evelyn, if you're able to.
Allô? Excusez. Bébis, il y a une question sur comment vous avez un DRC expliqué ou convaincre les parents pour donner le sel, et est-ce qu'il y a de sensitivité ou de collecte de sel dans le pays? Donc, est-ce que c'était difficile d'obtenir le sel pour les enfants? Ça, c'est la question. Merci.
OK, ça va. Merci beaucoup pour la question. Pour ce qui est des collectes de l'échantillon, dans le cadre de cette technique, nous avons, comme ça se passait avec GeneXpert, c'est une réaction PCR, pour qu'il n'y ait pas interaction entre les urines et la réaction PCR, on a demandé aux parents de faire très attention en prélevant le sel. Donc, on les a demandé de préférence que l'enfant puisse faire le sel sur un papier. Comme ça, le papier absorbe les urines et on reste juste avec le sel. C'est ce qu'on a demandé aux parents de faire. Donc, d'utiliser le papier, un papier propre, papier hygiénique, feuille d'arbre. Comme ça, l'enfant défecte sur cette feuille d'arbre-là. Ou soit utiliser le pot, le conteneur, dont la majorité des parents ont utilisé le conteneur, et lors du prélèvement, ils prélevaient que juste le sel et non le mélanger avec les urines.
OK, ça c'est clair. Mais l'autre partie de la question sera que le parent peut-être trouve ça difficile, pas comme faire, mais peut-être à raison de culture et quelque chose il n'aime pas pour donner un échantillon de sel.
Pour le parent, on n'a pas eu trop de difficultés, surtout qu'il y a certains parents qui, avant de se retrouver dans le site que nous avons retenu, d'abord nous devons savoir que le site que nous avons retenu, ce sont les sites qui ont dû faire l'étude CAPTIBI pendant au moins 4 ans. Et ces sites-là sont reconnus des sites qui diagnostiquent plus des enfants tuberculeux. Donc, ce sont plus des enfants dont le parent étaient déjà allés avec les enfants dans d'autres sites, ils n'avaient pas de solutions. Mais lorsqu'ils venaient avec l'enfant dans le site retenu pour le pilote et qu'on leur disait, OK, pour cet enfant, donnez-nous les selles, vous n'allez pas faire la radio qui est un peu coûtée ici chez nous, puisque c'est payant. Quand on demandait les selles, en tout cas, le parent était très satisfait, ne discutait même pas, il n'y avait pas eu de problème sur le prélèvement de l'eau. Surtout sur ça, parce que certains parents savaient déjà qu'en cas de tout, on doit faire une aspiration gastrique chez l'enfant. Or, avec les selles, il n'y aura pas d'aspiration gastrique à faire.
Ok, merci. Donc, je vais expliquer à les autres. So, I try to translate the questions for Bibis. So she gave two important insights. So first is on the instructions. They gave very clear instructions to the parents on how to collect the stool, maybe using a paper or a container, and to make it very easy for them to collect it if they had to collect it at home, because sometimes the child could not provide a sample on the spot at the health center. Then I asked further about whether there were any hesitance or parents had maybe problems with providing stools. She said overall there were no problems. Overall, parents, like we have also heard from the other speakers, were happy they could provide a sample and did not have to provide as alternative, for example, an invasive sample like gastric aspiration. Also, the sites that were included were before part of a CAP-TB project, which was focused around childhood TB, and at these sites more children are diagnosed, and parents had often gone maybe to already different health centers and were happy if they came at this health center that they got the opportunity for a diagnosis by providing stools. So there were no specific issues observed with providing stool samples. Thank you.
Thank you, Evelyn. So now we have come to the end of the questions. If there are any questions, we'll try to answer. We'll record them and send them answer by email or any other methods. I'm very happy to welcome Charlotte from USAID to give us our closing remarks. Over to you, Charlotte.
Thank you so much, Ndwele, and thank you to our colleagues at IDDS for organizing this webinar. I am so inspired every time I hear from our partners about all of these various efforts that are going on to improve diagnosis for children with TB. It's really incredibly inspiring. And one of the things I particularly appreciate about this group is that you really have built a great network for sharing experiences. And you know, so many countries, including the ones that presented today, represent a real range of experience from, you know, NTPs and stakeholders that have just done some initial piloting to, you know, groups that have really reached almost nationwide coverage or expert network coverage with this intervention. And being able to hear from all of you and you're being willing to share both the good experiences and the challenges that you've had is just incredibly helpful. And I think one really important lesson I'm taking away from this one is this importance of making sure that we not only have the technical pieces in place that we all know are important. We need to have the cartridges, we need to have the training, we need to have the testing procedures in place, but we also need to make sure we have this larger effort of case finding happening with children. So I know, for example, in Zimbabwe, you know, it wasn't just stool testing that was going on. It was this much larger effort. I know Zambia really also situated their stool testing efforts, and Nigeria as well, and all of you within this larger framework of case finding and improving case finding. And so that's a really, really important lesson learned. And I think finally, you know, this last part, hearing the questions around whether or not parents are comfortable and sort of whether or not there are barriers that we need to go further to address. I do think that the demand creation issue is one that's an important next frontier, really understanding where the barriers from the parent point of view, the caregiver point of view, provider point of view, you know, the laboratory staff point of view. These are all very different important stakeholders, and each one has different, we need to think of different strategies to reach each group to ensure that they are comfortable with the test and that we can make sure we can improve coverage. So I mean, I could talk for like 15 more minutes about how great you guys are, but we're at time. So I'll just end by saying thank you very, very much. Bye.
Thank you, Charlotte, for your remarks. Again, thank you all for joining. I want to thank all the presenters for the hard work they put in putting their presentation together. I want to thank all our partners that support us, Uganda Israel Mobile for donating the Truenat kits, KNCV TB Plus for starting out with the SOS method, and IHFBN Nigeria for allowing us to continue to do Truenat testing. Please, to learn more about pediatric and advancing pediatric TB activities, do continue to join the monthly community of practice meetings that USAID is hosting. And if you want more information about that, you can contact either of us on this slide and we'll connect you to that group. And thank you all again for joining, and goodbye.